All right, let's go ahead and get started. So thank you, everybody, for joining us today. Very excited to hear about the highlights from the European Respiratory Society's Congress and also some info from BEAT-PCD meeting that all happened in Amsterdam about a week, 10 days ago or so. If you're not familiar with Running on Air, we are a nonprofit with our mission being to help others breathe more easily through access to oxygen appropriate to their needs. But we also do educational webinars such as this one, and you'll see more of that on the next slide. But these are our social media accounts. You can follow us and keep up to date with some of the various lung information we share. We have 3 webinars coming up over the next several months. We have a PCD on the Move conference highlights, and that's happening in 2 weeks. We'll have highlights from the second North American Bronchiectasis and NTM conference in December. And then we have a portable oxygen concentrator basics and how to spot non-centrators webinar that'll be happening in January. Mike Hess and I will be hosting that. And then you can see some of the other planned webinars that we have. We're doing a whole conference highlight series next year. So usually the webinars, Amy and I co-host, and we're shaking things up a little bit today, and things aren't all going as planned. So Helga will be stepping in to help too, but Amy's here to help with the introductions. So I will turn it over to Amy.
Hi, everybody. I'm Amy Lietman. I'm the president of NTM Info and Research. We're an advocacy group for NTM and bronchiectasis patients. I'm sure a lot of you know about us. We have a network of support groups. We have 3 very informative websites now, a wonderful YouTube channel with a webinar library of over 120, a great support network forum for patients. And we also have a great pamphlet that you can order free copies of anytime you want. You can log on to ntminfo.org for more information. We'd like to thank INSMED for supporting today's webinar. Without their support and support of others like them, we could not bring this great programming to you. So a little housekeeping. This webinar is being recorded, the answer to the question that we get all the time. We will email a link to the recording once it is up and online. It may take a couple weeks. We will not be taking questions until the end of the webinar, so you can put those questions into the Q&A. We'll get to as many of them as we can. We will try our best. And also a reminder, Professor Chalmers cannot give personal medical advice. So if you're going to ask a question, please keep it as general as possible so that everybody can benefit from the information that's being given. All right, so I'd like to introduce today's speaker, Professor James Chalmers. He is the Asthma and Lung UK Chair of Respiratory Research at the University of Dundee and a consultant respiratory physician at Ninewells Hospital in Dundee. His main clinical interests are in difficult lung infections and particularly in bronchiectasis. He runs a research group focused on developing new treatments for bronchiectasis and related conditions. He chairs the European Bronchiectasis Registry and is the current chair of the European Respiratory Society Bronchiectasis Clinical Practice Guideline Panel. He is the current chief editor of the European Respiratory Journal. Dr. Chalmers, welcome and thank you for being here today.
Thank you so much. And let me start by saying thank you to Amy and Mary and your organizations for all of the hard work that you do raising the profile of bronchiectasis and NTM. It's hugely appreciated. And as you'll see from my talk, it's really making a difference now. The critical mass of patients and advocacy for this condition is leading to a large amount of new research. I'm going to talk you through the highlights from the ERS conference and a little bit from the linked PCD meeting, which is called the BEAT-PCD meeting. So I'm going to focus very much on new treatments. My overarching message is help is very much on the way in terms of new treatments that are coming for these conditions. And there was a lot of really exciting new science at the ERS conference and the PCD meeting. So I'm going to take you through a series of studies. I very much stuck to some of the key studies that were presented at the meeting, and the slides I'm going to show you are directly taken from the meeting, so nothing's been filtered. Because of that, A lot of them are quite scientific, but I will talk you through them so that you understand exactly what they're showing you and the key messages that have come through from the conference. So if anyone's not familiar with the ERS conference, the European Respiratory Society Conference is the largest scientific meeting for pulmonology, for respiratory medicine in the world. There were more than 20,000 healthcare professionals, clinicians, scientists, and others working in the respiratory field at that meeting, and also a large number of patients, including speaking in some of the sessions. There's a whole range of different sessions. So there's talks, there's industry symposia, there's a lot of posters, which is scientists presenting their new data, and then there's larger meetings where groups come together to try and stimulate new science. So it's a really exciting, dynamic meeting. And a lot of people reveal their new data for the first time at these meetings. And that certainly happened this time. There was a load of bronchiectasis. So lots for me to tell you about. What I'm going to tell you about in terms of the key events that took place at the conference is new trial data and data on new treatments. And I'm going to focus on a few of those, some positive, some negative, as you'll see in a moment. A big revolution in the last year and a half has been the arrival of the anti-inflammatory treatments, which are now reaching clinical practice in the US with FDA approval for brensocatib. There was a little bit of new data that I think is very exciting at the conference, and I want to spend a bit of time talking about that. And then one of the big moments for me and for the field at the conference was the release of the new ERS guidelines, which tell doctors around the world how to manage bronchiectasis. So I'll go through those as well. I really encourage you to ask lots of questions. I'm going to talk for about 45 minutes, and then we'll have at least half an hour for questions. So please ask anything you want, either related to the studies I'm going to show you or related to bronchiectasis in general. So the starting point here is we use a lot of different therapies to treat bronchiectasis all around the world. Many patients receive repeated courses of antibiotics. Those include long-term oral antibiotics like macrolides, azithromycin, antibiotics through a nebulizer. We use a lot of inhaled drugs, including inhaled steroid. And then to help with mucus symptoms, a lot of countries prescribe either oral drugs or inhaled drugs like hypertonic saline to try and clear mucus from the airway. It's very variable across different regions what people use. And the reason that it's so variable, it's different in the US, it's different in Europe, and the data I'm showing here is from Europe, because there haven't been a lot of big trials of a lot of these, what you might call old-fashioned therapies for bronchiectasis. So there's a lot of people in Europe take these oral tablets like carbamazepine or N-acetylcysteine that are meant to break up mucus. And a lot of people in Europe, but also in the US, use saline nebulizers to try and clear mucus. And the idea for those is that they should hydrate the mucus, so they draw water into the lungs and are meant to make the mucus more liquidy and therefore easier to cough up. So the first study I'm going to show you was presented for the first time at the conference and published at the same time in the New England Journal of Medicine. And this is hypertonic saline or carbamazepine in bronchiectasis. So this is a randomized controlled trial, and I'm sure many of you will be familiar with the idea of controlled trials, where people are randomly assigned via the equivalent of a coin toss to either a treatment or to no treatment or a placebo. So this was a study testing whether hypertonic saline or the tablets called carbamazepine improve symptoms or reduce exacerbations in people with bronchiectasis. So this was done just over 20 sites in the end in the UK, recruited through registries, including Embark, that I'm a part of. And patients were randomized to either hypertonic saline twice a day, and that's 6% via a nebulizer, carbamazepine, which is a tablet taken 3 times a day, both of those things, so the nebulizer and the tablets, or no treatment, which was described as standard of care. So you could get one of these 4 things. And the study aimed to enroll at least 300 people. The primary outcome, the main outcome, was whether or not this approach reduced exacerbations. And this is an important question because a lot of people are using these therapies. So it's important to know if they work and how well they work. So the study in the end enrolled 146 people to hypertonic saline, and 142 people didn't get hypertonic saline. 144 got carbocisteine, and 144 got no carbocisteine. This is a little bit complicated because some people remember that got both, and so are counted in each column. So overall, there's about 288 patients enrolled in the study. Most patients are female, which is typical of bronchiectasis studies, and the patients were of moderate severity. Pseudomonas colonization was uncommon. It's only about 10%. That's lower than you would expect in the United States. If we look at how severe patients' symptoms were, the St. George's Respiratory Questionnaire is a validated way of measuring symptoms. The score is about 40, so that's moderate symptoms. The patients weren't too bad, but they certainly had a lot of cough and sputum. And on average, people had 3 exacerbations in the year before the trial started. But you want to know, did it work? And the results were a tiny bit disappointing. So this is a table with all of the results, and I'll walk you through it. So what this is showing is the number of exacerbations in the study. So on average, patients had just under 1 exacerbation per patient over the year during the follow-up. And the number was the same whether you got carbocisteine or no carbocisteine. So it did not work to reduce exacerbations. There was also no difference at the end of the study in the symptom scores. You can see all these numbers are the same, lots of different questionnaires, whether or not people got the carbocisteine or not. And lung function was also not different. So we can conclusively say from this that carbocisteine tablets don't work, which is interesting because I showed you at the beginning that almost a third of people with bronchiectasis in the UK, where I work, are taking these tablets. So maybe we should stop them, at least for a significant number of people. The story is a little bit more nuanced for hypertonic saline. So this is the nebulizer with the salty water. The number of exacerbations was 0.75. That means roughly 3 out of 4 people having an exacerbation in the year taking hypertonic saline. And that was almost 1 person out of 1 having an exacerbation in the no hypertonic saline group. So the reduction was about 1/4 of an exacerbation per patient per year. Or another way of saying that is for every 4 people that took hypertonic saline, you would prevent 1 exacerbation. So it didn't work in that it's not statistically significant, but there is a signal there. There is some evidence that it works for some people, if that makes sense. The symptoms were not significantly different, and that's a bit surprising because a lot of patients do tell me that this seems to work for them. But overall, this is a negative trial also for hypertonic saline, but there's a signal for hypertonic saline that wasn't there for carbocisteine. So what I think this tells us is not that it doesn't work at all. What it means, I think, is that it doesn't work as a routine treatment for everybody with bronchiectasis. There are no subgroup data in the trial. So if you've got more symptoms or a worse cough, or you cough up a higher volume of sputum, does this mean you'll have a better effect from hypertonic saline? And that's work that's going on now to understand, are there small groups of people who will benefit from this treatment? But the overall message is a little bit disappointing that those types of treatments targeting mucus didn't show the kind of benefits that we were looking for. Okay, so I started off with the bad news so I can spend the rest of this 30 minutes or 40 minutes talking about good news, because all of the other trials, to me, seem to be really good news. And the next one I'm going to show you is the preliminary data of this came out at ATS, and then at ERS, full data of this trial came out. And this is the GREAT 2 trial. Many of you will know that pseudomonas is a big problem for people with bronchiectasis. Around 1/3 of people, or 1/4 to 1/3 of people with bronchiectasis, will become infected with pseudomonas, and it's associated with worse outcomes. The current treatment, the current standard treatment, is long-term antibiotics, either through a nebulizer or via tablets. Antibiotics have a lot of side effects, so it would be lovely to have a different treatment for pseudomonas. So in this trial that's called GREAT 2, this was led by a brilliant colleague of mine called Moretta Long, who's a translational scientist who's been working on this for several years. The investigators tested whether an antibody that target pseudomonas can reduce the amount of pseudomonas in the lungs and can reduce exacerbations and improve symptoms. And the advantage of this treatment is, unlike a nebulizer, which you take twice a day, this is an injection once a month and then you're done. You don't have to worry about the treatment. So potentially very attractive to patients because it's less burden. So what we did in this trial is we took patients who had bronchiectasis and a history of pseudomonas, and they had to test positive for pseudomonas at the beginning of the trial. And they were randomized via a coin toss to either a high dose of the antibody, which is called gramovimab, a low dose, or a placebo. And they got 3 injections to see whether it worked over that 3-month period. And then people were followed up for another 3 months to see that everything was okay after the injections. And the main outcome was to see whether the amount of pseudomonas was reduced and whether patients felt better. So this is quite a small trial because this is the first time this has ever been done. 37 patients were randomized, so 12, 13, and 12 took the different treatments, and everybody finished at least the treatment period. And as with the previous trial I showed you, most patients were females and most were around the age of 65. So the key question you want to know is, did it work? And it did. So the antibody, particularly at the lower dose, interestingly, reduced the amount of pseudomonas by about 99%. So it got rid of most of the pseudomonas, and it was statistically significant at the lower dose. It was also looking pretty good at the higher dose. So the antibody worked, 1 antibody injection once a month, and it reduced the pseudomonas for the duration of the treatment period. But what really got our attention is how much better patients felt on this treatment. So this is a questionnaire called the St. George's Respiratory Questionnaire. This is a measure of cough, sputum, breathlessness. And most people would say that they feel a lot better if the questionnaire improves by 4 points. In this study, it improved by between 10 and 12 points. So described by some of the patients as life-changing improvements in symptoms. It's a small study, so we need to see if this is repeated in larger numbers of patients, but incredibly exciting to see that level of symptom improvement because Pseudomonas often gives a lot of bad symptoms. And then it was a small trial and it was over a short duration, so we weren't necessarily expecting to see an effect on exacerbations, but we collected the exacerbation data and there was an 80% reduction in exacerbations at the high dose and a more than 60% reduction in exacerbations at the lower dose compared with placebo. So very few people who got the injection actually had exacerbations compared to the majority of people in the placebo group. So again, suggesting this antibody is really having a big effect. And then this is the effects on the inflammation in the lungs. So the reason I show this is the effect that we're seeing on the bug is similar to what you see with an antibiotic, but the injection seems to be making people feel a lot better than antibiotics do. So why would that be? I think it's because the antibody also affects the bug in a way that means that the bug doesn't cause as much inflammation. And our lab team have looked at this and showed that the amount of inflammation measured by neutrophil products like elastase and myeloperoxidase are much lower in people taking the antibody, particularly at the high dose, than people on the placebo. So what does all of this mean? This is going to go on to a larger study, but it's a very exciting idea that in the future, rather than having to take repeated courses of antibiotics or having to take antibiotic nebulizers twice a day, you could manage an infection like Pseudomonas by taking a monthly injection. That would be a real paradigm shift in how we manage long-term infections, which affect so many people with bronchiectasis. So really exciting data from the GREAT-2 trial. So the next trial I'm going to show you, similar but different. So the study I just showed you is the idea that an antibody boosting the immune response against Pseudomonas could prevent exacerbations and improve symptoms. Well, your body makes antibodies against lots of different things, and your antibodies become abnormal and dysfunctional as bronchiectasis gets more severe. That's what this study showed. For people who've got immune deficiencies, what we do for people who've got severe immune deficiencies is that we give injections of antibody to replace the body's normal antibody to fight off infection. So what if you could actually put antibody into the lung and allow the body to naturally, because that antibody is a natural way of fighting infection, naturally fight infections off more effectively. Antibodies also suppress inflammation, so could also improve some of the other features of bronchiectasis. And so this next study I'm going to show you was presented by Damien Downey from Belfast in one of the abstract sessions. And this is called CSL787, and it's a nebulizer containing antibody. And it's antibody actually that's come from the blood of healthy donors, plasma-derived normal human immunoglobulin. And the idea is if you nebulize this into the lungs, the antibody will then mop up any bacteria that are there, clear the infection, and suppress the inflammation. So this is an early study, what's called a phase 1 study, and it's testing, is it safe, and is there reason to go forward with the therapy? So the treatment was given for 14 days, 2 weeks, via nebulizer at 3 different doses. So high dose, medium dose, and low dose against a placebo, against a saline nebulizer. It included people who had bronchiectasis and reasonably good lung function. And because we're trying to kill bugs, it also included people who had one of these different bugs in their sputum at the first visit. And again, this is a small study, 24 people, 6, 6, 6, and 6 into the high dose, medium dose, and low dose, or the placebo group, and followed up, as I said, for 2 weeks, and then a bit longer for the safety period. And the main message of this was that inhaling antibody didn't seem to cause any major side effects. There were 2 people that had to discontinue the study, one because of a headache and one because of a COVID infection. Those are not likely to be due to the treatment. Patients had to stop because they had something else going on. So this looked like a very safe thing to do. It didn't seem to cause any major problems. So did it look like it was working? And this is the exciting bit. This is a graph showing over the 14 days and then the time off treatment, what happened to the bugs. And this green line is the level of the bugs in the lungs, in sputum, in people that got the placebo. And you can see that it goes up. So if you don't get any treatment, the bugs continue to grow. The low dose didn't do anything, but the high dose, the medium and the high doses reduced the level of the bugs quite a lot, actually reduced it to the level that we see with an antibiotic, and similar to the level that we saw in the GREAT-2 study with the antibody. So the medium and the high dose of the antibody seemed to be killing the bugs, which is really encouraging. And it even seemed to be able to kill pseudomonas, similar to what we saw with GREAT-2. And then we want to know, like we did with GREAT-2, like we did with the other study, did we see an improvement in symptoms? And the largest improvement in symptoms, which was 13 points on this questionnaire, was in the high dose group. Now, need to be careful with this because the placebo group also seemed to feel a bit better over the study period, maybe because they were taking saline through the nebulizer, which can sometimes make people feel as if they can cough things up a bit better. But it looked encouraging in terms of this antibody treatment improving symptoms. So another non-antibiotic treatment that might be able to help us to kill bugs and might be able to improve symptoms. This is also now going on to another larger clinical trial that's just kicking off, and it's called a phase 2 study, which is the next level of testing. And this is going to test the treatment over a minimum of 6 months in order to see whether this can produce benefits like reducing exacerbations. So that's really exciting. So I've shown you 2 new treatments that are not antibiotics, one that's an injection and one that's given via a nebulizer, that may be able to reduce the burden of infections and improve patient symptoms. So great to see so much new development in this field in bronchiectasis. So the second part of my talk, I said I was going to give you an update on some of the exciting developments around anti-inflammatory treatments. So the last time I gave a talk for Running on Air, the big news was the ASPEN trial, which is brensocatib, which has recently received FDA approval in the United States. And that's fantastic news for the field. And I'm delighted to see this treatment come through. For those who are not familiar with brensocatib, this is an anti-inflammatory treatment. It's taken as a once daily tablet, and it targets a white blood cell called the neutrophil, which is a major driver of inflammation in people with bronchiectasis. When you take this pill, it disarms some very important chemicals in the neutrophils called neutrophil proteases, like neutrophil elastase, and reduces the inflammation in the lungs. As a very quick reminder, brensocatib was approved by the FDA based on the results of the ASPEN trial, which randomized people to 25 milligrams of brensocatib or 10 milligrams versus placebo for 1 year. And it showed a 20% approximate reduction in exacerbations at both doses. There was no difference on this endpoint in both doses, and that's why the 10 milligram and the 25 milligram have been approved by the FDA. There was, however, a difference on lung function. So the 25 milligram slowed down the rate of decline in lung function, whereas the 10 milligram didn't show a significant difference. You can see this line with the lung function, the FEV1, is going down just as fast with the 10 milligram as the placebo, but there's this big difference at the end of the study for the 25 milligram. And that was also shown in the measure of lung volume, which is called FVC, forced vital capacity, with a big effect. 75 milliliters over a year is a big effect, where the lung function of people taking 25 milligrams brensocatib is quite different to people with placebo at the end of the study. So that's really important and suggests that the medication can actually slow down the progression of the disease, which is something that patients always tell me is really important. I want to make sure I don't get worse. So how brensocatib does that is a really interesting question. Is it affecting the bronchiectasis itself? Is it clearing out mucus, which some of our previous work suggested? We got some clues in the trial that it could be related to mucus and mucus symptoms. This is scores from the daily diary called the BEST diary, which measures symptoms. And what you see here is that because the medication works in the bone marrow, it takes about 4 weeks to work. And then after about 4 weeks, patients feel a lot better on the 25 milligram dose compared to the 10 milligram dose or the placebo group. So there's this clear difference in the symptoms. So based on the lung function and the symptom data, you might think, is the 25 milligram dose having a bigger effect on mucus? And so the new data that I presented at the European Respiratory Society Conference addresses this question about mucus. And this is the CT sub-study of ASPEN. And this is, I think this is really cool, exciting data. So the patients that participated in the ASPEN trial were amazing people. So over 1,700 people participated in that trial. But a small group of patients also volunteered very kindly to have a CT at the beginning of the study and at the end of the study, so that we could see what happened to the lung structure on CT over the 1 year that people were on the study. And in the end, 100 patients had scans at the beginning and the end of the trial to allow us to look at that. And the scans were scored using a scoring system called BEST CT. And what that does is it says there's 100% of the lung, and this is a picture of a CT, and you measure how much of the lung is taken up with bronchiectasis. And in this case, there's lots of mucus on this scan. So how much of the lung is taken up with mucus? And the yellow on this score is here is mucus. And you can see in some patients, 50% of the lung, this is data from our study, not from the ASPEN trial, just to be clear. 50% of the lung in this person is taken up with mucus. And in some people, it's only 2 or 3%. So it really varies between patients. So what does this look like in terms of the change in mucus when people take brensocatib? So this was the data I presented at the ERS, and the full data is going to be presented in a few days at CHEST. And the green ones are the ones at the top, are the ones that are significantly different. And the first one is mucus plugs. So this is areas of the lung that are plugged up with mucus that have bronchiectasis in them. And you can see here that in the placebo-treated patients, they actually had more mucus plugs at the end of the study. And there was this big reduction, particularly in the 25 milligram dose. So that's very important, because remember, it was the 25 milligram that showed the effect on symptoms and on lung function. In terms of mucus plugs in areas of the lung that are not bronchiectatic, that's going down very slightly in the placebo group in the 10, but look at the 25 milligram dose, a really big difference. So again, it makes sense. The 25 milligram dose is having this effect on lung function and symptoms, and that's linked to a bigger effect on mucus. That's different when we look at bronchiectasis, which is just widening of the airway tubes, where there's not much difference between the two doses. But because mucus is such a big part of this, when we look at healthy airways, the largest difference is an improvement in healthy lung in the 25 milligram dose. So why is this important? I would say it's for two reasons. One is it really strengthens the idea that this is having a disease-modifying effect. It's stopping the lungs from getting worse. And looking at mucus as a measure of getting worse, it's even reversing some of the changes that we see in bronchiectasis. That's really exciting. But the other thing is the FDA in the US has approved the 25 milligram dose and the 10 milligram dose. So doctors will be asking themselves and patients will be asking themselves, which of those two doses should I take? Looking at this data, the lung function and the symptoms, if I was a patient and my doctor was asking me, I would want the 25 milligram dose because all of the data other than the exacerbation data seems to be pointing for me to an advantage of the 25 milligram dose. So that I think is really nice new data. Many of you will know that there's two other DPP-1 inhibitors, these new anti-inflammatory drugs that are in development. And the other one that is now in phase 3, which is the last stage of development before it can reach patients, is called verducatab. And this was, again, data that I've shown previously in a running on air webinar. This was tested in a trial called AirLeaf, where 3 doses of verducatab were tested against placebo. And the 5 milligram dose and the 2.5 milligram dose were expected to show an effect. The 1 milligram dose is subtherapeutic. This trial included a very similar patient population to Aspen, people with a history of exacerbations and producing sputum on a regular basis. And it included a broad range of different causes of bronchiectasis, including asthma, COPD. And for the purposes of this presentation, I'm going to mention primary ciliary dyskinesia, because this was some data that came out at the PCD meeting that was linked to the ERS. So there was just under 30 patients with PCD in this trial. And we're interested to know, do these new drugs work in all the different types of bronchiectasis, or are there some groups of patients that do better than others? And so this analysis I'm going to show you is aimed at answering that question. So overall, and this has been shown before, there was an approximately 30% reduction in the risk of an exacerbation at the 2 effective doses, which is 2.5 milligrams and 5 milligrams. So less exacerbations with verducatab versus placebo. When we look at the subgroups, so what this is showing, and I'm going to focus on the 2.5 milligram dose here, is this line is a line showing no effect. And if there's anything to the left of this line, that means that the drug is having an effect on exacerbations similar to the overall. And what you see is that the medication seems to be working in almost all the groups, males and females, older people and younger people, people with pseudomonas, people without pseudomonas, people on macrolide, people not, and on different underlying causes. But the other etiologies are not broken out into, COPD, asthma, etc. So for an exploratory analysis, we looked at the patients with PCD, remembering that there's just under 30 of them. So for that, we pooled the 2.5 and the 5 milligram doses because those both showed a 30% effect on exacerbations. And what we showed is that there's actually more inflammation in people with PCD. This is the levels of neutrophilic inflammation in the airway than in people without PCD. So you might predict from that, because there's more of the target to hit, that the medication might work as well or better. And what we showed in the exploratory analysis of people with PCD, this is people in the placebo group, and you can see about 60% of people had an exacerbation, and that was reduced to less than 50% in the people with PCD. So overall, a meaningful reduction in the exacerbation frequency in people with PCD. So this strengthens the view that the new DPP inhibitors should work across a wide range of people with bronchiectasis, including those with other types of disease, including some of the genetic causes. And this drug, which is called verducatab, is now entering phase 3 studies. That study's kicked off, and it's including a very wide range of patients, including actually people with cystic fibrosis and PCD, those rare genetic causes of bronchiectasis. So that's a trial called AIRtivity, and it's testing the new drug that's called verducatab, 2.5 milligrams versus placebo. So again, great to see so many new trials coming in this disease where there used to be very little clinical trial activity. So the last thing I'm going to talk about before we move to the questions is the release of the ERS Clinical Practice Guidelines for Bronchiectasis, which came out at the Congress. So guidelines tell doctors how they should manage bronchiectasis. And although this is an ERS guideline, it's intended to be a global guideline. There were 3 representatives from the United States on the clinical guideline panel. So these have been written also with a view to management in every part of the world, including the United States. And what we do in these guidelines is that we review the evidence for all of the different treatments that doctors or healthcare professionals might want to use for bronchiectasis, and we come out with a decision based on the evidence of whether or not we can recommend something or whether we should say, actually, this shouldn't be used. So in this guideline, we came out with recommendations around the 4 different key components of the disease. So there are anti-inflammatory medications, anti-infective antibiotic medications, things to clear mucus, including mucoactive drugs, and then things to deal with the consequences of lung damage. And we try and address all 4 of those things in this document. And we make recommendations that are either strong or conditional. Where we say strong, it means we really think there's good evidence to say you should do this. Where we say conditional, it means a bit more of doubt here. So we made the best decision that we could, but more evidence may come out in the future. So the first thing that we said in this guideline is that it's really important to try and find out what caused people's bronchiectasis and to do an assessment of whether people with bronchiectasis are at high risk of complications. So we come out with an algorithm for the kinds of tests that should be done by doctors when they diagnose bronchiectasis for the first time. And what this says is that you should be tested for certain types of antibodies. You should be tested for whether you've got an allergy to a thing called aspergillus that causes about 10% of bronchiectasis, and that every patient with bronchiectasis should be tested for NTM. So that's really important because these things are all underdiagnosed. NTM is often missed. And then in people who have specific types of bronchiectasis, depending on where it is on the scan, the type of symptoms that you have, the types of bacteria that you have in your sputum, and other features, we come out with other suggestions of what types of tests we may want to do. But these aren't routine tests for everybody. So this, I think, will really help doctors to get to the bottom of what's going on with people with bronchiectasis, but it also leads to specific treatments. If you're diagnosed with NTM, that will change your treatment. If you're diagnosed with aspergillus, that will change your treatment. So we hope this will drive doctors to do better testing, and ultimately you as patients will get better treatments. So the next bit here is to say it's really important to know, as a patient, are you somebody that's mild, moderate, or severe? Are you somebody that has a high risk of future complications, or are you at low risk? And so we've identified in the guideline, and this is the first time this has been done in a comprehensive way, who are the people who we should be most worried about and be most aggressive with treatment. And we say in this that people with COPD, PCD, rheumatoid arthritis, associated bronchiectasis are at higher risk. If you've got pseudomonas or other gram-negative bugs in your sputum, you're higher risk. If you're having frequent exacerbations or you've been hospitalized for exacerbations, you're at higher risk. If you cough up very large amounts of sputum every day, you're at higher risk. NTM and aspergillus. Again, we hope this will help doctors to identify people where we need to watch patients more carefully and start treatments earlier. This is not meant to scare anybody. If you happen to fall into any of these categories, it doesn't mean that something terrible is going to happen. It means doctors need to monitor you a bit more closely to make sure that nothing untoward is going to happen. Likewise, you can be severe without having any of these things, but you're more likely if you have these things to have severe disease. So again, this is very important, but very clear guidance for doctors on what to do. We recommend in the guideline that everybody with bronchiectasis should be taught how to do airway clearance techniques. So if anybody who's a patient on this call doesn't know how to do exercises to clear their chest, that's something that we should talk about, because this is a very strong recommendation. Airway clearance, airway clearance, airway clearance is highly effective, and it should be something that everybody with bronchiectasis has a chance to do. And it's best taught by a respiratory physiotherapist, and we say that clearly in the guideline, but there's no one technique that's better than the other. So everybody does things slightly differently. And at the moment, we say that's okay, because we need head-to-head studies to know what's the best method of airway clearance. Going back to the first study that I showed you, which said that mucoactive drugs don't work for everybody, should active drugs be used in people with bronchiectasis? What we've recommended is that they can be used as a last resort in people that have tried airway clearance and other treatments and are still having very difficult symptoms. So we say, based on those studies, don't use them for everybody, but they may work for some people, and it can be tried on a case-by-case basis. But it should be part of a comprehensive airway clearance regime. So not just trying drugs, we should try airway clearance exercises or adjuncts before we go to things like hypertonic saline. Exercise is incredibly important, and we make a strong recommendation that patients with bronchiectasis should be offered rehabilitation if that's available in your healthcare setting, and that patients should take regular physical exercise. The quality of evidence for this is low. There's not a lot of randomized studies, but it's the right thing to do because exercise is very effective for you as patients. So those are sort of the non-pharmacological treatments. And the second part is the drug treatments that we can offer for bronchiectasis. And this is a summary of what kind of things we can potentially offer. So we have, for inflammation, the long-term macrolides have very good evidence for them. They're not appropriate for people with NTM by themselves, but for people without NTM, there is a role there. There's more evidence for long-term nebulized antibiotics, and we recommend those particularly for people with pseudomonas. And then pseudomonas eradication, we make a weak recommendation for the first time you grow pseudomonas to try to clear that with an antibiotic. So this is the summary of that. For nebulized antibiotics, we do think that should be tried in people with pseudomonas infections if people are having a lot of exacerbations. And that's the nebulizer that contains things like tobramycin or colamycin. And that's really for people who are having frequent exacerbations. But we do say that you need to test dose the nebulizer because some people just can't take them because of intolerance. For the long-term macrolides, we make a strong recommendation to use those if people are having lots of exacerbations despite doing airway clearance. And so this is the schematic for what we suggest to do for people who are at high risk of exacerbation. So we say optimize all of the other things, which includes airway clearance, treating the underlying cause, comorbidities, vaccinations, etc. And then if things are still problematic, if you've not got pseudomonas, the best treatment will be a macrolide. Now, of course, this will also in the future feature brensocatib. And from a European perspective, which is where I practice, we need to understand where that fits alongside macrolide. And then for people with pseudomonas, it's either a macrolide or an inhaled antibiotic. And again, from a US perspective, brensocatib will now enter that mix as well for people at higher risk of exacerbation. We obviously didn't have that when we were making the guideline. And then we say people should be given these treatments for 12 months. If they don't work, obviously stop them and switch to a different treatment. If they are effective, then aim to continue. So the idea here, particularly with this idea of at risk of exacerbation, is, and the idea of that severity assessment is to say, we don't want people to be having very frequent exacerbations. They really impact on quality of life and they make the disease get worse over time. So our guidelines are now much more aggressive at saying, let's try to stop as many exacerbations as we can with these medications that have been shown to be effective. The last couple of things I'll mention, inhaled steroid are not recommended if you don't have COPD or asthma. Again, this is one of these things that might work for individual people, but it really shouldn't be used for everybody with bronchiectasis. An eradication treatment is getting a short course, meaning 6 weeks or 3 months of antibiotics when you first get pseudomonas to try and stop it taking root in the lungs. And we make a weak recommendation for that, but there is a great need for randomized trials in that area. So that's the end of the presentation and the end of what I wanted to talk to you about. The summary of the guideline is when you see all the ticks here, we now have lots of different treatments that have been proven to work to a level that we can recommend them in a guideline to target the different aspects of the vicious vortex. So as a patient with bronchiectasis, you should be thinking about airway clearance, exercise, and then medications that can help to improve your quality of life and prevent the risk of exacerbation. And then from the first part of my talk, I hope I've given you a flavor of how exciting the new treatments are in terms of what's coming, not just brensocatib, which is really going to change the game in terms of thinking about disease progression in the future, but also some of the other new treatments that are coming, which may replace some of our antibiotic treatments and give us new options that are not going to have such a big risk of resistance. So I'm super excited about the future. The ERS was by far the biggest conference for new bronchiectasis news that I've ever been at. And I think it will just keep on getting bigger and bigger now that bronchiectasis has hit the mainstream. So with that, thank you again to Mary and the team for inviting me to speak. I'm delighted to take some questions.
Thank you so much, Professor Chalmers. Definitely very exciting information and a lot to process. So before we get to the questions, I just want to let everybody know that you will be receiving an email from Running on Air within the next 24 hours. And we're going to give you links to some of the things Professor Chalmers mentioned. I think we can probably get a link to the guidelines to share. And one of the papers you mentioned at the beginning that was introduced at ERS, we can send a link to that. That'll give you the summary. And you will get a second email from us in a few weeks once this recording is online.
So I was just going to say, Mary, we've actually, with the European Lung Foundation, we've made a patient-friendly booklet on the guidelines, and also with a little checklist where you can check if your doctor has given you all the treatments that it says you should have from the guidelines, which we hope is going to stimulate our doctors a little bit. So if you're willing, I'll send those to you and you could maybe help us get those out.
That would be great. Yeah, absolutely. Thank you so much. Yeah, we'll include that in the email then. So let me just see. And the other thing I just wanted to mention, we'll also email out a link to a webinar that Dr. Pamela McShane did for us 2 years now ago, I think, on airway clearance. Since Professor Chalmers brought that up, it was a very good webinar talking about some of the various techniques. So that would definitely be a good place to start if you are not familiar with airway clearance.
Yes, definitely.
All right. So Helga and I are going to alternate asking questions. And the one other thing, sorry, I wanted to mention, because somebody did ask this, the webinars that I showed at the beginning, the ones that we do have scheduled, I will include links to those in the email that'll go out in the next 24 hours too. So you can register for those. Okay, first question. Will brensocatib, which is brensocatib, 25 milligrams, slow progression of bronchiectasis as well as reduce episodes of flare-ups? And you covered that, but since it was being asked.
That's okay. It's my favorite question. So when I presented this at the conference, I was sort of dying for somebody to ask me the question about dose, because I feel quite strongly about this, having been quite heavily involved in the trials and having seen a lot of the data. I would really want the 25 milligram dose if I was a patient, because although the exacerbation data is the same, the disease progression data is not the same. So the ones I showed are FEV1, which is how much you can blow out in 1 second. So that's measuring whether the airflow is obstructed. Forced vital capacity, which is the volume of the lungs. So that's a total measure of your lung health. And then I showed you the data from the CT where the 25 milligram dose in particular was unplugging the mucus. and seem to be having a much bigger effect. So I think that the 25 milligram dose will have a bigger effect on your mucus symptoms if that's something that's a big problem for you, but is also likely to allow you to keep your lungs healthier for longer because of the effects on lung function. So I think that there is very good evidence that there's a disease-modifying effect of the 25 milligram dose.
Okay, we have a question here. What are the names of medications to remove mucus that work and do not utilize a nebulizer?
Okay, good question. So I showed you the trial from the conference with the medication that unfortunately didn't work. So the medication that didn't work was called carbocisteine. So it's given 3 times a day as a tablet, and it's meant to break up the viscosity of the mucus. Some patients say it works, but this trial didn't show that it works. There is another one that is similar, but slightly different because it's also an antioxidant called N-acetylcysteine. And it's actually available in many countries over the counter because it's a widely used safe antioxidant. But the medical form is used a lot in the UK as a mucus reducing agent, and that's called N-acetylcysteine. I'm not recommending those particularly because we don't have great trial data to show that they work, but they seem to help some patients. The advantage of N-acetylcysteine, it's available as a once daily tablet. We do need better mucus drugs. There's a few in clinical trials at the moment, but most of them are given as nebulizers. The ones I've mentioned, at least the advantage is that tablets are easier to take.
All right. Along those same lines, hypertonic saline nebulizing twice a day is very time consuming. Would a lesser amount still be effective?
A really great question. The honest answer is I don't know. I would like to ask the person who asked the question whether they feel that it's effective, because what that trial showed, the CLEAR trial, which I showed you at the beginning, was that in 288 people with bronchiectasis, overall, there was only a very small effect on exacerbations of the treatment. So for most people, hypertonic saline wasn't making any difference. And what the questionnaire raises is very important. Nebulizing twice a day takes a long time. So it needs to be really working for you, I think, for it to be worth the investment of the time. So I think if I was a person taking hypertonic saline after those results, I'd probably have a chat with my doctor about, do we think this is really working for me? Or are there other treatments I could be taking? And as an example, I've just shown you that brensocatib dries up lots of mucus, and that's proven to work. So if hypertonic saline isn't working for people, maybe a daily tablet will make a difference. But don't take the wrong message. I don't think everybody on hypertonic saline should stop it. I think it does work for some people, but probably only for some people. My practice going forward will be to try it for a few months. And if people say, I feel wonderful on this, keep going. But if it doesn't work, to stop it after a few months, because it's not going to work for most people.
Okay, would granulomab be used for colonized pseudomonas, not an active infection?
That's a really great question. So granulomab was this pseudomonas antibody that I talked about. So that was the monthly injection that seemed to kill pseudomonas and improve people's symptoms. And it was that trial was all people who were long-term colonized with pseudomonas. So they'd had it probably for several years. There's no reason it wouldn't work for acute pseudomonas as well, but we've just not trialed it in that group. And I think it would be really nice in future to trial it in that group as well, try and stop people getting pseudomonas in the first place. But all of the data I showed you is for colonized.
Okay, Helga, I'm going to ask the next two because I'm going to answer the first one.
Okay, go ahead.
How can we sign up for these clinical trials on the positive phase 1 trials? In the email in the next 24 hours, we'll include a link to, I think it's clinicaltrials.gov. And there is the phase 3 trial that is starting to enroll patients. Is it Airtivity?
So yeah, Airtivity is the phase 3 for verducativ, and then there's a phase 2 for the 2 antibody treatments that I mentioned.
Okay.
So lots of things.
So we'll send links for that in the US. Now, the clinicaltrials.gov does list trials throughout the world. And Professor Chalmers, if there is like a European specific equivalent for people to kind of look at what trials might be enrolling, that would be great if you could share that.
So for Europe, clinicaltrials.gov is perfect as well. So all of the trials that enroll in Europe are usually registered on there. The other thing I would add to what Mary just said is when you see your doctor or your healthcare professional, ask them the question, are there any trials going on that I might be able to get involved in? We love when people ask us that question because sometimes we're nervous about asking people about participation in trials. So it's wonderful when people ask. And at the moment, there are so many really exciting new treatments coming. The best things that I can offer my patients are all things that are available in clinical trials. So please do ask your doctor because there are some great things out there that are now becoming available to patients through trials.
All right. Since brensocatib or Brinsupri treats neutrophilic inflammation, is it recommended for bronchiectasis patients being treated with biologics for eosinophilic asthma?
So great question. Brensocatib is not approved for eosinophilic asthma. It's only approved for non-CF bronchiectasis. But if you've got asthma plus bronchiectasis, there were people in the ASPEN trial who had a primary diagnosis of bronchiectasis and also had asthma at the same time. There was no difference in the effect if people had high levels of eosinophils or low levels of eosinophils. So having a diagnosis of asthma wouldn't stop you from using brensocatib as long as you also have the main problem that you have is bronchiectasis. I hope that makes sense.
Yes.
Okay, must you do airway clearance twice a day or can once a day for people who don't produce a lot of mucus be sufficient?
Really great question. So I think, and everybody's view on this is different, and I bet you PJ McShane might give you a different answer to me. I think what works for you is the right way to do airway clearance. Okay, I think patients with bronchiectasis generally know whether they're congested or not. And after they've done a clearance session, a lot of my patients are able to say, yeah, I feel as if I've got a result, I feel clearer or not. So if you're doing it twice a day and you're not getting much of a result and you're not feeling that it's giving you any benefit, you've got to ask the question, why are you doing it? So if doing it once a day, you feel clear for the rest of the day, that's fine with me. This is a really common question I get from my patients because a lot of patients tell me that they wake up in the morning quite congested. But once they've done their treatments and done their airway clearance in the morning, for the rest of the day, they feel quite clear and they don't feel like they need to clear in the evening. For me, that's absolutely fine. If you're controlling your disease well, your symptoms are good and you're not having exacerbations doing it once a day, that's absolutely fine. There's no perfect way. The best way is the one that works for you.
All right, I'm going to read the next question. And just so you know, this is not my question. And you'll know why when I start the first part. I have PCD, and I get usually around 3 to 4 different bacteria, which drive lung infections and exacerbations. Is there a way I can increase immunity? And are regular antibiotics a good solution long term? I have the feeling they lose effectiveness over time.
So this is a really good question. So people with PCD, the primary ciliary dyskinesia is a genetic condition where the hairs, the little cilia, this is the international sign for cilia, where the little cilia don't work. And so you don't clear mucus from the airways effectively. And so you end up with more severe bronchiectasis and you're more likely to pick up bugs like pseudomonas. I look after a lot of people with PCD. It's one of my major areas of interest. It's one of the things that brought me into bronchiectasis. Long-term antibiotics are a really good treatment for PCD, okay? So the macrolides, which is azithromycin long-term, are one of the few things that's been proven in PCD to be highly effective. They cut exacerbations by more than 50%. And there isn't much evidence that they lose effectiveness over time because their effect is mostly anti-inflammatory. I've got PCD patients who've been on azithromycin for 15 years and they're still being very effective for people. And if you've got pseudomonas, the other treatment that works is using the nebulizer with the antibiotic. And a lot of my PCD patients take those. And as I showed you in the slides that I presented, that exciting data, the DPP1 inhibitors trials also included people with PCD. So they are captured within the indication for non-CF bronchiectasis. And so maybe something also to think about. So that would be my suggestion for people with PCD. Don't suffer in silence with lots of symptoms and lots of exacerbations. The treatments can actually be very effective. So talk to your doctor about the treatments that are recommended by the guidelines.
Okay, so we have a question. Why no corticosteroids for inflammation?
Oh, great. One of my favorite questions. So your question makes complete sense because we're taught that corticosteroids are anti-inflammatories, but nobody ever teaches us that there's two different types of inflammation. Yeah, sometimes called type 1 and type 2. And sometimes in the asthma clinics, they even talk with patients about type 1 and type 2. So corticosteroids target the type of inflammation that we see in asthma most commonly, which is called type 2. Neutrophilic inflammation, which is sometimes also called type 1, is what you see most commonly in bronchiectasis. So people with bronchiectasis have the wrong type of inflammation for steroids, or steroids are wrong for the type of inflammation that people with bronchiectasis have. And that's the whole reason why the class of drugs that brensocatib and verducatib belong to have been developed, because they target the neutrophil side. So that's the reason. It's only about 20% of people with bronchiectasis have the type of inflammation that responds to a steroid. So some people with bronchiectasis absolutely should stay on the steroid. Don't go home and stop it because Professor Chalmers told you to. Talk to your doctor about it, because some people really do need the steroid, but it's only about 20% of people with bronchiectasis.
Okay, so we have some patients don't cough up sputum even after using airway clearance. Why is this?
Really good question. So there's two possible explanations for that. And this is, for me as a doctor, this is a little bit tricky. So some people don't cough up sputum because there's genuinely no sputum there. We call that dry bronchiectasis. It's not common. You remember that graph I showed you of the different CT scans? So maybe 1 in 10 people didn't have mucus on the scan when we did that big study of over 500 people. But there are some people that don't have mucus. And that means that the airways have been damaged, but there's not a lot of inflammation to cause the mucus to be there. So in that situation, there's nothing that we need to do. It's good. Hopefully that means that the symptoms will be well controlled. Unfortunately, there's also another group of people who do airway clearance and they get no result, but they do feel congested and they get chest infections. And when you look on the scan, there's actually a lot of mucus very deep down in the lungs. And that means that the airway clearance that they're doing is not effective enough, or that the mucus is just too viscous to clear. And that's where some of the mucus drugs that we talked about can be helpful. I certainly do that for some of my patients, where a physiotherapist, it's not uncommon that I will have a patient who says, I can't ever get a sputum sample. And they'll go through to see Ali, my physio colleague, and 20 minutes later, there'll be a big sputum sample in front of me because Ali's managed to get them to expectorate by doing really good physio. So that, as a doctor, that's the thing that we need to sort out. For you as a patient, if you feel like that, the next time you see your doctor, ask them, can you see any mucus on my scan, or do I look clear?
Name more mycolytic drug examples, please.
Okay, so
sorry for my
no,
pronunciation. But I'm glad you understand.
Absolutely no problem. So mucolytic, which means to cut or to break down. So mucolytic, things that cut mucus up. So the ones that are most widely used are carbamazepine and N-acetylcysteine, which are the tablets. Again, very little evidence that they work. And then hypertonic saline and normal saline, which are given by a nebulizer. And very occasionally, because it's used in cystic fibrosis, people use a drug called mannitol, which is another one of these. And the other one that's not recommended in bronchiectasis, but does sometimes get used, is Dornase alpha, or DNase. It's approved for cystic fibrosis, but not recommended in bronchiectasis, but I do occasionally use it for some of my patients with primary ciliary dyskinesia when they have very thick mucus, because what it does is really thin the mucus down. So there's a bunch of drugs that do target mucus. Again, I would say none of them have great evidence. So they will be right for some people, but not for most people. As we move into an inflammation era in bronchiectasis, we should also be thinking, rather than targeting the mucus, target why do people make so much mucus, which is reducing the inflammation with things like the macrolides and the new DPP1 drugs.
All right. So this person's excited about some of the potentially upcoming treatments and trials, and asks how far away, if all continues well, in next phases, especially the antibody one.
So that's a really good question. So we've talked a bit in this webinar about phase 1, phase 2, phase 3, haven't we? So those are the 3 phases that drugs have to get through. Phase 1, is it safe? Phase 2, is it likely to work? And then phase 3 is definitively, does this work and can it go onto the market? So it has to go through all 3 of those phases before a new treatment hits the market. So all of the ones I showed you are at different stages of those things. So brensocatib's already on the market, which is fantastic. Verducativ is probably 3 years away or something like that, because that's the phase 3 sort of timeline. Phase 2 is maybe 5 or a little bit more years away, and phase 1's even longer than that. So that gives you an idea of the sort of timelines for these therapies. So the antibody that I showed you is in phase 2. So unfortunately, that is, before it's available to everybody in the US, is probably 5+ years away. But the trial is kicking off in the US, if not right now, within months. So it'll be all over the US. Talk to your doctor and say, could I get involved in that trial? Because that's how you get access to these new treatments early on. And a lot of these trials, after the end of the trial, offer either open label extensions or access programs. And what that means is when you finish the trial, if you've done well, you can stay on the drug. And that's a really nice thing. That means that participating in a clinical trial, you can not just benefit everybody else, but also potentially benefit yourself by getting earlier access to a treatment.
I'll also add to that, in the phase 3 trials, you may be on the placebo, but when you're done with the trial, then you might be able to get the drug. You won't continue taking a placebo.
So that's right. Most of those later phase trials offer that chance for people to switch over onto the real thing, which is great, because we can say to patients, no matter what happens, at some point you're going to get the real thing.
Right. And you won't know until the trial's over whether you had the placebo during the trial or not. But in that next part of it, you would be getting it. All right. So this question asks about other types of pseudomonas. So what about other species, especially pseudomonas otitis? And that was found in the sputum of a PCD patient. They ask, is it aggressive? And is it useful to treat as we would pseudomonas aeruginosa?
So this is,
should we try to eradicate, wait until symptoms? And so are there other pseudomonases that are pathogenic?
So there are lots of other pseudomonases. So the common ones that I see are things like Pseudomonas putida, Pseudomonas luteola. This one I've also seen. They are less pathogenic than Pseudomonas aeruginosa, so they're less able to cause disease in the lungs. So they tend not to persist. So they cause an acute infection, but they tend not to cause long-term infection the way Pseudomonas does. So with these ones, what I would usually do is give a short course of antibiotics for 2 weeks, and usually that's enough to get rid of them, as opposed to Pseudomonas, which often sticks around for longer. So as with all of these things, if you've got that bug, talk to your doctor, but be reassured that it's very unlikely to cause a long-term infection the way Pseudomonas aeruginosa does. That's one of the most common questions I get from other doctors that are not experienced with managing bronchiectasis, because they see a lot of these bugs and people are never quite sure what to do with them.
So along those lines, would you do the same process of doing a culture to get the right antibiotic for that form of Pseudomonas?
Yeah, so those pseudomonases are usually only susceptible to one type of oral antibiotic, which is the fluoroquinolone, ciprofloxacin, or levofloxacin, but you would get an antibiogram to make sure that you were giving the right thing.
Great, thank you.
Okay, so somebody's asking about a Brainine inhaler.
Yeah, so I'm not familiar with that one. Breyna, is that it's maybe a US brand name for something which...
Yeah,
Yeah,
the person
I
is
hadn't heard
asking
of that
whether
either.
you would,
Okay,
you recommend it.
I've found it. It's a generic inhaled steroid LABA combination inhaler. So the Breyna inhaler is not recommended for everybody with bronchiectasis. It's recommended if you've got coexisting asthma or COPD, or if your doctor thinks that you have a specific type of inflammation that would respond to that type of inhaler. But in general, the guidelines say not to use those types of inhalers routinely.
Okay, so somebody's asking, is there any new airway clearance methods discussed?
So the short answer is sadly no. There were no new trials of airway clearance at the conference. I mentioned in my talk that there's actually almost no head-to-head studies of different types of airway clearance. So that's something that we really need because it's a really neglected area of this field. We're hoping to kick off through the European network some trials of physiotherapy interventions because it's nice to have lots of new drugs, but some of these simple things that we all do all the time still need some evidence for them.
So somebody's asking whether these studies are published in Google Scholar. I'm not familiar with that.
Yeah, so some of the studies that I showed you are published, like the CLEAR trial, which was the hypertonic saline carbocisteine one. Some of the stuff that's presented at the ERS has not been published yet because it's late breaking news. So it will come out in publication form in the next few months. But all of the data, you're going to share all of these slides anyway, Mary. So all of this data will be available to people through the slides and the recording of the webinar.
All right. So in the trial where you were talking about the injection, it's asking if it will kill Pseudomonas aeruginosa, especially in patients with chronic colonization.
Yeah, so that was really cool. In that trial, it reduced it by more than 99%. So it didn't kill all of the Pseudomonas, but it killed a very large amount of the Pseudomonas. So I think the question, does it kill Pseudomonas? The answer is yes. If you mean, is it going to get rid of it completely? At the moment, it doesn't look like that's the case, but we don't know what will happen when we give it for longer than 3 months. So it's possible it doesn't get rid of it. It's also possible we just didn't give it for long enough to see whether some people could get rid of the bug, if that makes sense.
Yep.
Okay, here we have a question going back to a little bit of airway clearance. What are studies showing on the use of the vest with or after nebulizing?
Yeah, so there's quite a lot of data on the vest. So the vest is very widely used. There's a lot of registry data and a lot of observational data from the vest where people are given the vest and you can show better symptoms, quality of life, reduced exacerbations after using these treatments. They've not been tested in randomized trials. So a lot of this is just asking patients how they got on with it, which is prone to a little bit of bias because there's no control group, but it does suggest that along with the other types of airway clearance methods, the vest seems to be effective for many patients.
All right. Yeah, we seem to have a little row of airway clearance questions here.
That's good. Airway clearance is important.
Yep. Hypertonic saline nebulizing may not work for exacerbations, but doesn't it help move mucus up and out to keep us clear with less risk of infections?
So in that trial that I showed you, in 288 people, taking hypertonic saline didn't cut the risk of infection and didn't reduce their sensation of symptoms. But that's in 288 people. It doesn't mean that there weren't people within that study where it did feel as if it made them better. So I think my answer to your question would be for some people it will, for many people it won't. So what I'm going to be doing going forward with hypertonic saline is just as your question suggests, after about 3 months, I'll ask my patients, do you feel that nebulizer helps you to get the mucus up? Are you getting more of a result because of the saline? And if they say yes, I'll say, continue. That seems to be doing a good job for you. And if they say no, then I will stop it because the trial suggests that for a lot of people, it doesn't work. And that makes sense. Nothing works for everybody.
So I'm going to ask another question along those lines. Do you have any experience with patients that tell you hypertonic saline helps only sometimes? That's this person's experience, and it depends on their daily condition, if it really works or if only works for humidifying the lungs.
Yeah, so we tell people to take hypertonic saline twice a day, but my patients are very educated and they understand their condition very well. Some of my patients will come into clinic and tell me, I take my hypertonic saline 3 times a week. I take it on days when I feel very congested because I don't feel it benefits me except when I've got a lot of mucus there to clear. To me, that's fine. If that works for you, that's great. I really think in bronchiectasis, particularly with airway clearance, it's all about finding something that works for you and means that you feel clear most of the time. So don't feel pressurized into using things that you don't feel benefit you, because this is all about improving symptoms. So yes is the answer. I do think there are some people where just using it intermittently is absolutely fine.
Okay, we have another question here. Would a combination treatment with brensocatib and trifata for bronchiectasis patients with one CF gene mutation be an option? Any known interaction? It is my understanding that CF patients with one gene mutation were not in the test.
Yeah, so this is a really great question. Sorry, they keep giving you the hardest ones to pronounce, Helga.
I know.
So, yeah, Trikafta's a tough one. Trikafta's a really tough one. So just for everybody who's on the call, in case you're not familiar with these, Trikafta is a drug that corrects the cystic fibrosis gene. So it's used for people with cystic fibrosis, and it has really dramatic effects in people who've got CF. People who've got non-CF bronchiectasis don't usually have a defective CF gene, and so those drugs are not available for people without CF. Some people with non-CF bronchiectasis, and this is where it gets a bit confusing, have one abnormal CF gene. So that means that they don't have CF, but their secretions might be drier than other people because of the one CF gene. So there is a trial going on at the moment. It's at Emory. I think it's just in the one center where people with non-CF bronchiectasis are being trialed with Trikafta. So we'll find out from that if there's any reason to believe that it works in those people. My prediction is it may have an effect. It probably won't have as big an effect as it does in CF, but I'd be surprised if it doesn't do something because it hydrates mucus. Would it work also with brensocatib? I don't know, is the answer, because brensocatib itself has a very good effect at reducing the amount of mucus. So maybe you wouldn't need one if you're taking the other. I think we'll find out. In this case, brensocatib is proven to work in this disease. Trikafta's not. So if people are interested in Trikafta, I would say let's see if we can get into those trials and find out whether it works.
All right. Well, we're down to our last few minutes. So I'm going to ask one more question. And this, is there any research in the works in the EU for macrolide-resistant M. abscessus?
So the answer to that question is there is an international platform trial that's being run out of Australia that is including sites in Europe. And I think it may also be including sites in the US, but I can't be sure. That's doing a bunch of new drugs for M. abscessus specifically. So macrolide-resistant M. abscessus is very tough to treat. There aren't that many new drugs in NTM, but there are new trials coming through. And as I say, what a platform trial is where you test multiple new drugs at the same time. So it's a very efficient way of doing trials. And so that's really starting to pick up speed across the world to try and find new things for M. abscessus. So I would say, yes, there are things coming, and watch this space.
All right. Well, that brought us right to 2:30 on the East Coast of the US. All right, Professor Chalmers, I want to thank you for joining us today. This was really, as always, a great webinar, very encouraging, very enlightening. Thank you to everybody who stayed on with us for the hour and a half. Again, you will get an email in the next 24 hours that will have some of the links that we've discussed during the webinar. I also want to thank Amy and especially Helga too for stepping in to help out today. And thank you.
And thank you so much for me. Really great webinar.
Thank you, Professor Chalmers. Take care,
Great to
everyone.
work with you, Mary. Bye-bye now.
Thanks. Bye.